You're listening to 9 Plus, a research podcast from Waterford Institute of Technology. My name is Rob O'Connor. I'm an academic with the Department of Computing and Mathematics at WIT, but I'm recording these podcasts so that I can learn more about the work being carried out by colleagues across the Institute. There's some genuinely fascinating research being conducted by individuals and groups, and there's a good chance you don't know that it's happening. We're often locked away in our own little bubbles, and hopefully these podcasts are an easy way to get an idea as to what's going on elsewhere, in a convenient 40-minute-ish package. In this episode, we're talking about the positive effects of physical exercise on patients suffering from mental health issues. My guest is Dr. Evan Matthews, who completed his PhD in 2019 entitled Developing a Physical Activity Programme for People with Severe Mental Illness using an Experience-Based Co-Design Approach. Evan has been working with the HSE and Mental Health Ireland to pilot a programme called The Exercise Effect in County Wexford, which has led to extremely positive outcomes for the individuals involved. The findings will be published in the next few weeks, but Evan and I sat down to have a chat about setting the scene, where the work was coming from, and also outlining where it might go in the not too distant future. I began our conversation by asking Evan to describe his current job at WIT.
So my current role, it's convoluted. It's a research fellow in the Department of Nursing and Healthcare. So that's actually a fellowship that's funded by the Health Service, specifically by the Nursing Midwifery Planning Group for the HSE. So I'm funded essentially by the Health Service, and I'm based in the Department of Nursing and Healthcare. But I suppose my research, it spans more than nursing as well. It's beyond the scope of just nursing practice to health issues. So my own personal research profile would focus on health behaviours that affect marginalised populations. Okay, so I'm going to ask you about your background in a little while, but I'd like to talk to you about a project that you've just recently finished or are in a stage of finishing, and there is a report due to be published with the HSE soon. It's The Exercise Effect. You ran this in Wexford via the Sláinte Care Integration Fund. Could you explain what that project is? Yeah, or what that project was? Absolutely, yeah. So we're at the end of the first year of that project, and the project will continue. So essentially, in brief, what the project is we leveraged money on a long-standing ambition of mine. As part of my PhD, one of the kind of strands of my PhD was I wanted to change the way we deliver exercise as part of routine care in Irish mental health services. And one of the best ways to do that, Rob, is to have an exercise practitioner. That's someone who's specifically interested, specifically tasked to support people to do exercise or physical activity. So when we say exercise, we mean that structured exercise that could be in a gym, could be out in the park, wherever in their home, but it's structured. Physical activity is beyond that. It's exercise included, but it's also movement, breaking up sedentary behaviours. It's all the other incidental movements that we do in our day-to-day lives. So what we want to do in that project is have a practitioner working as part of the mental health team that was tasked to address that issue, because what we know from the literature is that and some of the studies that we looked at before during my PhD is if you don't have that person there, exercise and physical activity is it's everyone's concern, but no one's responsibility. Okay, now I'm going to back you up. Why is it important? I know I'm playing devil's advocate here, okay, and I'm deliberately putting this up to you. Somebody has a mental health issue, psychosis, schizophrenia, whatever it might be, okay, and I obviously don't know what this is, right? That's a mental issue. Why should I be concerned with physical exercise? Sure. So, I mean, there's a couple of strands to that question. I suppose first we have to... It probably is a lot to unpack, yeah. We have to separate this out a bit. So, with that project, and I should say it was a collaboration project, and, you know, was led by my supervisor at the time, is Suzanne Deneve, and then we worked as a team together on that project, among many other colleagues, some in WIT. But in that project, we're focused on specialist mental health services. So that's targeted at people who have what we call a severe mental illness. So they would have a diagnosis of something like schizophrenia, bipolar disorder, or major depression. So it's a little bit different from the average person on the street who might have challenges with what we call maybe common mental disorders. So they're at a more severe end of the mental health spectrum. Let's call it that.
And you're focusing on young people specifically, is it?
With that project, no, we weren't. We were focused on people across the lifespan. So the project actually reached into services for older people with severe mental health problems, adults with severe mental health problems, and children and adolescents with severe mental health problems. So the project was far-reaching. So coming back to your question there, like, why is this important? Exercise is important for a number of different reasons for that population. Okay, so we can kind of separate that maybe into two kind of overarching reasons of importance. And the first is people who have those severe mental illnesses, they actually have a reduced life expectancy compared to people who don't have those conditions. And the general population, we have a poor understanding of those illnesses, but actually what's going on there is what's killing those populations early is a burden of physical illness that is disproportionately felt for those populations. So they have things like diabetes, cardiovascular disease, and those illnesses are creating this burden of ill health for that group, and that unfortunately reduces their life expectancy.
Okay, and why is that?
So again,
I know that's a very broad question.
Yeah, it's a very hard thing to unpack, and this work has been led by people that I've been fortunate to have mentorship and connection with during my PhD study. But really, it's multifaceted. For one, it can be to do with stigma, and stigma can come in a lot of different shapes and sizes. Yeah. Stigma can be something as simple as the people that are there to care for those people in mental health services, the nurses, the doctors, they're very focused on the mental side effects, and very often the physical stuff gets neglected. That doesn't come packaged as the stigma that you and I might expect stigma to come packaged as, but in a sense it is, because it's just the way we've done things, and we need to re-look at how we actually treat and manage those populations in care settings. So even something like, as well, the medications, and medication has a role, don't get me wrong here. Some of the medications for mental health populations are very, very effective, but some of them can have some significant side effects. Parking all that aside, that's the way things maybe are. What we're not doing is actually addressing the lifestyle behaviours and supporting people to change their lifestyle behaviours when they have a mental health problem. So, for instance, there's one study led by mentors of mine in Australia, and they had young people who came into the mental health services with what's called first episode of psychosis. So these people that would probably go on to develop schizophrenia. And they noticed that in how these people are usually treated is they gain an awful lot of weight. They gain up to something like beyond 8 kgs of body weight just in the first few weeks of taking these antipsychotic medications. So it's unnecessary. But they realised through like a randomised control trial, which is where you compare one group against the other. So they compared this intervention of exercise and eating properly through support of these practitioners, like an exercise practitioner or a dietitian. And they compared that to the usual care, and they realised they can actually they can offset all of that weight gain from taking those antipsychotic medications. So it really begs the question is, why are we not doing this? Why aren't we actually putting supports in place for people with these mental health problems to address those physical health issues?
So I just want to clarify this in my head. So what you're saying is, this study was particularly with young people in Australia, and they're diagnosed, they present with the condition, and they're on an antipsychotic medicine, which has its benefits for their mental health, but it's having a negative effect on their physical health, in that you're saying they're putting on about 8 kilograms in a few weeks.
Yeah.
I'm not the smallest lad in the world, and I'm about 70 kilograms. So it's more than a tenth of my body weight.
Yeah.
That's a lot. Like 8 kilograms, that's a lot.
Yeah.
Particularly for a young person who may not be as physically large.
Yeah, and can you imagine as well, if you were just starting out a journey of poor mental health, you're accessing a mental health service, you're going through all these changes, you're an adolescent, which brings with it an awful lot of other challenges in life as well.
Yes.
And then your body is shifted and changed into something that it doesn't normally look like too. It's going to have a compounding effect on your mental health, which is why they're there in the first place.
Now, again, I'm only asking because I don't know, right? Is the weight gain a direct result of the medicine, or is it a secondary effect of the medicine, or is it both?
It's very hard to unpick all these things.
Okay.
So, you know, there is good, robust evidence from some of the top tier types of studies, so what we call meta-analyses, where you pool data together to come up with an answer. And there's good evidence from that to show that, you know, medication is an independent risk factor in that weight gain. It is, okay?
So when you say an independent risk factor, and I know I'm stopping you in your flow the whole time, but what is that? What does that mean?
It means that if you... And no research is perfect, okay? So, yep. But in the evidence, and I should say, this is the studies that look at this weight gain in schizophrenia. It's not research that I've led. I'm familiar with the research area, but I wouldn't speak with great authority. But let's go back to your question. So, it's an independent risk factor insofar as if you look at the data and you try as best to control for other measures, you can still isolate that as a primary factor that is potentially causal.
Yes.
in that weight gain. There are other issues there at play for sure for those populations as to why they will gain such a disproportionate amount of weight when they start on a journey of recovery, let's say, in their mental health. So for instance, you might be talking about someone who has been having some symptoms, and these symptoms are very confusing, very scary for the individual. They might start to pull away from their friends. They might start to neglect their diet. They might start to smoke to cope with something like the anxiety that comes with it. So there is an awful lot of compounding factors. And to be honest with you, it's very hard to separate out those factors. There's no research that's going to be able to be pure enough to separate out those factors. But the best evidence available can show, you know, where there are primary risk factors, let's call them, or independent risk factors. And medication can be a risk factor. But again, this thing it's always a balance, you know, and when someone is acutely mentally unwell, medication has its place because, you have to deal with what's in front of you at the time. So obviously, it's not to take away from medication. It has its place, but the important message in where our research has been looking at is if you have the right structures in place as part of the mental health services, that weight gain doesn't have to be inevitable. That weight gain is actually potentially avoidable.
So particularly for a young person, but for any person, gaining that much weight in a short period of time would surely add stress or add to anxiety, which could amplify other issues that might be at play there. And would I be correct in saying what you're looking at doing, or what your project, the exercise effect, and also the work in Australia had done, was to try and not put that weight on in the first place, because it's easier to not put it on than to shift it off. As anyone who's ever been through Christmas or COVID or whatever, it's easier to not put on weight than it is to take it off. Is that fair enough now, or is that too simplistic?
It's not simplistic. I mean, it is fair enough. Interesting, actually, and the weight is an important element to it. Okay, so yes, in the younger populations that we would have had the intervention, and we were a little bit concerned that, or we were a little bit hopeful that we could have some impact on offsetting that weight gain. Okay, we weren't. That, I mean, if you look at the evidence that's out there available to you, if you use just exercise alone, it's as you said, it's quite hard to shift weight through exercise alone. You do need a robust and long-term lifestyle adaptation for weight gain, and then you've got the other things like the medications that are also going to have an impact on weight gain. So really, where the Exercise Effect Project, which is where we had the practitioner into the mental health services, and as part of that project we had to work to create that role essentially and make that role acceptable among other services. But really where that has its strength is actually the mental health outcomes. So across the diagnosis spectrum, let's call it, across all those different diagnoses that I mentioned. When you have exercise as a therapeutic intervention delivered by someone who knows what they're talking about and someone who can support you and understand your mental health problems, you can actually shift a lot of the burden of mental health symptoms. So you can reduce symptoms of anxiety, you can reduce symptoms of depression. The other thing that in mental health care, and this goes for medications too, there's no such thing as a cure-all,
Yes.
Some things work for others better than they do for the next group of people. But for the most part, the evidence up there for exercise is really, really strong right now. So as I said, there's colleagues of mine that I've had the fortune of being able to work with, but they have led some, again, that top tier evidence, that meta-analytic evidence, so that, they're bringing studies together to look at the one answer. And for the most part, you can show a strong, significant effect of exercise on treating symptoms like depression for people who have major depression, managing anxiety in people who have schizophrenia, improving cognition for people who have schizophrenia. So these are really, really important things that determine how a person's quality of life, how good a person's quality of life is, if you get me. So these are places where exercise, if delivered as part of the routine care package, can improve a person's quality of life.
So I'm asking you simplistic questions, and I do understand that this is complex. Okay, but I'm trying to understand it myself because I don't understand. Could you maybe give an example of how the practitioner operated, or you don't obviously have to use real names or anything like that, in the program that ran in Wexford? How was it set up? What did they do? What was the kind of stuff that was going on? That kind of give us a gist of it, if you know what I mean. Yeah, so
it was important that we have that person as integrated into what's called a multidisciplinary care team. That's a very, very HSE kind of term. Essentially, it means that you've the team of the nurse, the occupational therapist, the psychiatrist, all those different people. And what happens is you've a person who's in a particular service. Let's say they're in a child and adolescent mental health service, and they have contact with that multidisciplinary care team, and that team sets out what's called a care plan. So we wanted to, as best as possible, to bring that person into that team, into that network. Now that's a very challenging thing to do, and we had to use the support of Sports Active Wexford, so that's the local sports partnership, to do that. But through creating, and this was part of the project, is creating special agreements that are in place that allows the person to work as part of that team, to have access to the care plan, the medical notes of the service users. So that was part of the project. So they work as part of that team. They feed information into that team. They relay information back as to how that person is getting on, what they're doing, the progress they're making. But as part of that, then as well, you also have things like the person, the let's call them the exercise practitioner. They're meeting the service user one-to-one. Had to be one-to-one because at the time COVID-19 was an issue, so we couldn't do the group sessions that were planned. But they would meet the individuals. They would take them through a structured exercise routine, also introduce them to physical activity opportunities that are going on in their community that the person might have been less inclined to engage with because of maybe they might have social anxiety and things like that. But they would help them to get set up and get going in those community-based programs. And then importantly as well, the practitioner has the ability to monitor the exercise, the physical activity. So there's tools specifically for mental health that fortunately I've been involved in the research around those tools. Again, that's work led in Australia by a guy called Professor Simon Rosenbaum and Phil Ward. So I had the opportunity to work with them on that and to create that tool and to develop that tool. So we use that tool then so the practitioner could see, well, how is, Rob getting on? What's the progress? And that's a more valid measure of how the person's getting on because it's for the mental health populations. And then also importantly, the practitioner has the skills because they're an exercise and health science graduate. So they have the skills to have these therapeutic conversations, be able to motivate a person, understand the mental health symptoms as well, know when to back off, and be empathetic and support them in their journey to getting more physically active. So if I was to be again reductive, it's kind of like a very specialised form of personal training. In a sense, you could call it that. Yeah, it's.
But obviously, there's a medical element to it as well. Yeah,
there's a medical element to it insofar as they are part of a mental health team, and they have a skill set and an understanding. So the practitioner would have gone through training to get up to speed with mental health diagnoses, because it's important that they have a handle on that and what to do if they see a certain presentation or things like that. So
and I'd imagine that so when you're talking about an exercise program, it's not right. Let's go out and run a half marathon today. It's obviously going to have to be tailored to the individual, and as you said, this is spanning various ages, and I'm sure the different levels of fitness. So it has to be specific to the individual. Is that?
So the skill set of the practitioner is vitally important as part of the project. So now the project is scaled up. We have more practitioners coming on stream. So I mean, obviously I'm not involved in the day-to-day running of the project. I'm very much providing or supporting with research oversight and feeding into some of the project design issues, but I wouldn't be on the ground every day with the practitioner, let's say. But essentially it's very important that they have those skill set to tailor, as you said, for populations across the lifespan. And again, with mental health as well, like you could be talking about someone who might have an awful lot of anxiety around exercise, might have a fear of exercise, but they also might have symptoms that might preclude them from exercising outdoors in public spaces. So you do need to have the practitioner needs to have the capacity to grade exercise appropriately, introduce exercise appropriately, and educate the person and the mental health team around the value of it. So that's a very important element to it as well.
So the way you're describing it, so you have the kind of the clinical team and the nurses, psychiatrists, doctors, other therapists, other support services, and the practitioners in there, and they're all in the mix. It sounds like quite a holistic team.
That's the ideal. So, a lot of this idea, we're actually very far behind in Ireland. So fortunately, I wrote a paper on this in 2018 before this practitioner existed. So myself and my wonderful PhD supervisors, we wrote a paper on this to say, why are we doing this in Ireland? So this happens in a lot of other contexts, but we're not doing it in Ireland. We don't have that holistic approach. We don't have an exercise practitioner, and they're doing it in the likes of Australia. So I got to...
But you said it's actually worse. It's not just that you don't have an exercise practitioner, it's that the services aren't linked up at all. Now, you told me this when we were having a cup of coffee, but you might just describe what that is. This is not to cut the back off anyone, it's just to kind of set the scene as to why your work is important and why it has an effect.
So this comes back to stigma, and as I said, stigma can be an undercurrent, let's call it. It's not necessarily overt. So traditionally how we conceptualize mental health services is mental health services appear separate to the other medical services in your hospital. Even if you go in, if you go down to if you need to access the Department of Psychiatry in Waterford General Hospital next week, okay, you're going to find yourself in the basement of the hospital. It's separate from the rest of the services. We treat mental health services very, very differently, and therefore we have a very poor, as a population, we have a very poor understanding of mental illness. Now that is changing, but it's a long road to go. And yes, essentially what has happened is we have focused the attention on the mental health symptoms. We have trained our mental health professionals to address, and rightfully so, address the mental health symptoms and challenges that present to those populations. But we have neglected to understand the physical health issues that are also connected to people who have mental health symptoms. So unfortunately, your head is connected to your body. Those two things aren't separate, and we have not looked at mental health in that way. And they are connected. So unfortunately, as I said earlier, people with mental health illness, they die 15 to 20 years younger than the general population, and that's because of cardiovascular disease. That's because of issues with their physical health. You're going to find an awful lot of obesity, you're going to find an awful lot of diabetes, more so than the general population in these mental health populations. And that's because we're not looking at it, we're not treating it, and we're not managing it. And part of that is, as you said, the word holistic. We're not providing holistic care. We don't have a clear pathway. We don't have good interventions in place in our mental health services to look at these issues and address these issues. And it's not just exercise, of course. It's dietary. It's looking at smoking. That's there's greater incidence of smoking in these populations. It's a complete picture, and we've a long way to go in Ireland to improve the situation.
Now, I know I've been asking you lots of kind of high level questions because I'm trying to get a handle on this. I obviously don't know about this, but when you're referring to that, you're not saying, oh, these people are bad. I'm not talking about the patients. I'm talking about the psychiatrists. It's not the psychiatrists are bad. It's just that this is the way the system has been set up. They're doing their best. The nurses are doing their best. The various other therapists are doing their best. But they're in this siloed setup, perhaps. And what you're talking about with the Exercise Effect project that ran in Wexford is that there were a whole group of practitioners brought together to treat the patient as a kind of a whole. Is that fair? Is that a fair description?
Yeah, so siloed is the word. It's completely siloed, and as you said, that's no one's fault. In fact, as part of my research, I spent hours and hours and hours in different psychiatric settings, and they're amongst the hardest working professionals you'll meet, and overstretched to the bone.
Absolutely, yeah.
But yeah, it's the way they were trained. It's the culture that exists because of the way people were trained and the way things were done before. And as part of what the Exercise Effect project was, what we were looking at as well, was that issue of culture. Like, is this going to be accepted by the other professionals? So obviously, if you want people to engage with the project, you need to know, are the other practitioners going to refer to the exercise practitioner? Are they going to give it time at the meetings? All these issues, are they going to follow up? Are they engaging? Are they working together? And that, part of as the evaluation team that Suzanne Denis, colleagues, and I were involved with, we were looking at those issues. Were those issues addressed? And for the most part, that takes a lot of work. You can't just parachute a new person into a service and let them go. That takes work on the ground. That takes meeting people, listening to them, understanding their issues, understanding their concerns, working with them, as opposed to kind of, here you go, here's your practitioner. So that's a long process, and we definitely, as a project, we didn't get it all right, but we learnt a lot by doing it. And the evaluation, the research piece is very important to understand that and to improve that going forward for this next year too, where we scale up.
And what did you get much buy-in and acceptance from the traditional mental health team to this exercise practitioner?
Yeah, so listen, I mean, we did 100%. Better in some places than others, where sometimes it comes down to people, where people have a vested interest in this. So some people, were already trying to use a little bit of exercise as part of, their job. You might have a nurse or an occupational therapist in one particular service who would they swear by exercise for their own mental health, and they just wanted to do something, but they didn't have the time, the energy, or the skill set to do that. So you would have maybe good buy-in in some of those places. In other places, there was a bit more resistance. In some cases, people don't always value exercise. They haven't got a full appreciation that the evidence is there and how robust that evidence is. And in other cases, as far as they're concerned, there were bigger things happening, and there's issues around risk and things like that. So in those cases, we have more work to do to shift that mindset. But that's part of the process. So if you look to the literature, to do this right, and in other contexts, you have to address that cultural shift, and there's lots of different ways to do that, but it doesn't happen overnight, and we didn't expect it to happen overnight, but we could see from our research findings that where there were successes and why there were successes, and what we need to do differently. Okay,
so can you describe what the findings of the Exercise Effect project in Wexford were? Even at a high level, okay.
Yeah, I mean, so we looked at a number of different findings, so there are lots of different outcomes. So first of all, as you would hope to expect, we see that service users that got involved in the program, they do more physical activity and they did less sedentary behaviour. That's actually a really, really important finding. That is our primary currency in this project, was increased physical activity and reduced sedentary behaviour, which for people with severe mental illness is really, really a big issue. Okay, so that's number one.
And obviously that goes back to what you were talking about, cardiovascular disease, diabetes, and those issues that could potentially lead to reduced lifespan.
Yeah, but it's more than that, Rob. So I mean, if you look at like for example, there's a really good randomized control trial, right? With a randomized control trial, again, you compare one group versus the other group. One group has the treatment, the other group has the control or does nothing, and you compare the two. There's a really, really interesting study that was done in the US where they flipped that model. Okay, so they actually asked one group to sit. So in a sense, you're actually giving them the bad intervention, let's call it that. They actually asked them to sit more than others. And this was a healthy population. So one group was sitting, they had to sit for a prolonged period of time throughout the day, and the other group were just told, go about, do what you normally do. And they looked at the outcomes after 1 week. And in just 1 week, you see a dramatic impact on people's mood. So this is the general population, sure, but you see the group that were sitting for a prolonged period of time, their mood deteriorated rapidly and significantly over just 1 week. What's interesting then as well is once you let those people go back to their normal activities and they assess their mood again, it returned to normal. So yes, the cardiovascular disease, the diabetes, those were issues that are the rationale for doing the project. But really, there's a fundamental reason why you would increase or try to increase people's physical activity levels for the here and now, for today, and that's to improve their mood, their symptoms, anxiety. Yeah. And we could do that. So we looked at some of those outcomes as well. We found for those that were involved in the project, they did improve in those outcomes, and we could look at that through what's called our quantitative data, where we looked at the assessments that were carried out and had scores for different tests that we ran, but we also talked to people and interviewed them and looked at their experience of the project, and we see that in both those kind of data outcomes.
So long-term effect is better general physical health, which leads to less instances or could lead to less instances of these issues that you've mentioned that can shorten lifespan. But a very short-term effect, as actually an immediate effect, the way you're describing it, is somebody feels better. Absolutely. I mean, it feels better inside. Yeah,
and that's where we actually really should be shifting our focus.
Yeah.
That's how we actually sell this to the practitioners, the psychiatrists, the psychologists. That's the golden ticket for getting exercise as part of the routine care. This is an additional toolkit for the mental health services. This will improve mood. It has comparable effects to some of the mainstream treatments that are being used by the services at the moment anyway. Why wouldn't we look at doing this as part of a service? And the best way to do it for mental health services is to have someone who's there looking after it. Okay.
And it doesn't have to be... So, sorry, I interrupted you the way you were describing the findings. Are you happy with the way that those have been described? Because I know I interrupted you.
Yeah, well, I mean, I mentioned that, so physical activity outcomes and then mental health outcomes. We looked at that too, but we also looked at what's working and what's not working about it. And as I mentioned, we had to adapt an awful lot during COVID, so we had to do an awful lot of what's called telehealth interventions, so remote interventions. When I say we, I mean the practitioner. I was providing oversight and research support to it, but she was providing those telehealth interventions. And that works well for some, so that's really an effective way to reach adolescents in the mental health services, and it worked really well. But obviously, it wasn't as effective for reaching some of the older populations. Well, I shouldn't say obviously, but in that case, it didn't. It wasn't as effective in reaching the older populations. And there were some just kind of more logistical findings that came out through it. How do we improve this, and what's needed to improve it, and making people aware of the project and things like that. So there were some of those more logistical findings too. So the project, the phase one of the project, or part one of the project, or however you describe it, that's finished now. And you have a report that's due to be published before the end of the year. Mm-hmm. So that'll be available through, I suppose, the usual HSE channels. But then you're moving on to a second phase, are you? Yeah, so as you said, we're going to write up that. Well, we have written up that report, and it's sitting with the publisher right now, so it's under the last bit of review. But that will go out soon. And then, actually, to scale up the project, we had to bring in the help of Mental Health Ireland to kind of support and facilitate that scale up of the project. So there's now going to be 4 exercise practitioners working in Wexford Mental Health Services, and fortunately, and you no idea how much joy this gives me to say it, because it's been a mission of mine for the last 6 years. I have mental health services banging on my door now asking, how do we get this? How did you do it? What's needed? And that's great, because back in 2018, Suzanne and I, and of course Mary Cowman too, who's since retired from WIT, we ran an initiative in WIT where we invited local mental health services in, and we talked to them about the benefits of exercise for treatment and things like that. And they loved that, and they found it very interesting, but they said, this is never going to happen in Ireland. The HSE is never going to fund this kind of stuff. And it hasn't happened yet, but we are on the crest of the wave. I feel it's just about to happen, because we have showed such strong findings in our Wexford project. We have momentum and appetite from other services approaching us looking for more, and I feel that it's a point of change right now, that we're going to see this in the next hopefully 5 to 6 years in mental health services, these practitioners working across services, and that would be just so good for unfortunately a population that's been neglected in a lot of ways.
Well, I'm finding this fascinating. I'm very interested in this. It sounds. I hate to be reductive, but I don't have the clinical language. But it sounds like a no-brainer. I can't see a downside to this.
Absolutely, and unfortunately the only downside has been we couldn't up till now really show that we could really save money, but as I said, this is a comparable sort of intervention to other mainstream interventions, and it has the added side prong of the physical health benefits too. So essentially it's a no-brainer, Rob, and it's being done in other contexts, and we are slow in Ireland, and it has been my mission as part of our research over the last six years to shift this.
Let's talk about where you're coming from, because this is like you. So here you are now, like you're a relatively young person yourself. You've just completed your PhD. Was this part of your PhD or came out of your PhD?
Yeah, it's spun off out of it. So I finished my PhD in 2019. So I'm a Waterford IT through and through, so I educated the whole way up.
But you're from Kilkenny though.
I am, yeah. Which I think has only adds strength to my work. But anyway,
it does.
So yeah, it spun off out of my PhD. So my PhD looked at a number of different aspects of how do we get exercise into the mental health services. We didn't really focus too heavily on the role of the practitioner. Actually, in my PhD, we were looking more at how do we get service users to take up this issue and be involved in the process of program development. So that was more what my PhD was looking at, but we were also looking at ways of measuring activity as well. And then it kind of spun off out of it. So during the course of my PhD, I was fortunate enough to spend a bit of time in the University of New South Wales in Sydney. With the School of Psychiatry there. As I said, I have some incredible mentors there as well, with Philip Ward and Simon Rosenbaum and others. And I spent a little bit of time with them, and I saw what was happening there in their services, and I was flabbergasted. It made so much sense. As you said, it was no-brainer sort of stuff. But it was really, really effective too. And there's a psychiatrist over there called Jackie Curtis, and she was facilitating this work in their service because she was seeing these physical health issues with their population. It was only after they tried to address the physical health issues they realised they were improving mental health stuff as well. Yeah. And they were producing these, good quality trials on it. And I got to spend some time there and work with them and we're doing things like developing the tools to measure it and stuff like that. And I came back to Waterford completely reinvigorated. I just had to do something about this, and Simon and Phil, they both came over to Ireland and they worked with us on how we do that, and supported our research here with Suzanne and Mary. And it's just grown from strength to strength. And even after my PhD, I spent the last 2 years in a postdoc position, and shortly I'll be moving on to a lecturing role in physical activity. But this mission of mine will not die. I am determined that we can use exercise and other lifestyle interventions as part of our mental health services, because we haven't done it in Ireland, and we are now 10 years behind where we should be.
So, but that sounds very, very positive and also very heartening. But if I can just be a little bit selfish for a moment. So when you were doing your PhD, how long did you spend in Australia?
I only just spent, I think it was 2 months, maybe a month and a half, but it was enough to give me a kick in the backside.
Was it good crack?
It was stunning. Yeah, it was stunning. I mean, I was we're in a radio studio in Waterford right now, but I was working in an office in Bondi, in the Bondi Health Centre, and it's pretty good over there. I'm not gonna lie. It's a different vibe. I had Bondi Beach not too far away, and we were having a good time and got to do a little bit of travelling around, and we presented some of our research at different conferences in Australia, and met some incredible researchers, incredible academics that are pioneering this, and it opened my eyes, in terms of, like, I was probably working away on my PhD in Waterford. I was going maybe between different mental health services, back to the office, working away, writing, and it just shifted everything for me, Rob. It just kind of expanded my horizon in a huge way. I started to reach out to other academics. I got mentorship from not just Australia, and now I'm fortunate to have mentorship, and I'm actually working and supervising other PhD students with some of these colleagues as well from Manchester. Rebecca Carney is over in Manchester. I'm working with her, and it brought my research scope from the southeast of Ireland to global, and made my connections global, and it makes for a better researcher, I think. Not that I'm a good researcher. I'm very conscious as well that I'm following Geraldine Canny, who's a Harvard graduate. I feel like you might have stepped down on this one, but
but I mean, it sounds to me like you have a bit of imposter syndrome, and the work that you're describing to me sounds incredibly interesting and incredibly impactful, and you're crediting a lot of other people, and rightly so. But maybe you should credit yourself as well.
Listen, everything I do is part of a team. So I always work as part of a team, and it makes for stronger research. You won't get terribly far in research if you're not working as part of a team. And a team, for me, there's a strong foundation in WIT. I have a very, very strong foundational team in WIT. I go back to people that I know are really, really hardworking in WIT and do everything for me. And if you go and look at any of my publications, WIT names all over the page. But then there's maybe a helping hand from international experts as well that have supported me. And I to be honest with you, I learned everything from them. So it's not right for me to not credit them. We've done a lot in Waterford and the southeast of Ireland to change services here locally. But my ideas were supported by others.
If you ever decide to change from research into politics, you're off to a good start, I think, because you're very good at spreading the love around. Right. One last question for you, Evan. If somebody was thinking about getting into research or starting a postgrad or whatever, if you had one bit of advice for them, what would it be?
It's a good question, Rob. Okay, so
it's a broad question.
It is. So as you said there, I probably have a bit of imposter syndrome. I do. I was not what you'd say classically academic in secondary school.
Yeah.
I did not know what I wanted to do. I had a little bit of creativity. I could write a little bit, but I couldn't really spell very well. I couldn't do maths very well. I wasn't very strong academically, and I loved playing sports. Played a lot of sports, and I just put something down on the CEO. I put a load of stuff down about sports and exercise, and got into a course that I found I actually really love. And when I was doing something I really loved, I realised I was academic. And it's about, I think, finding out what actually interests you, what you're going to read on a dark Sunday evening, what actually really sparks your interest, what will you sit down and read. And once you've identified that, you'll become an academic. I didn't even know what an academic was when I was doing my undergrad. I didn't know what a PhD was, other than doctor in front of your name, but that meant nothing to me. But once I found something that really sparked my interest, I just went for it. and it grew, and with a little bit of help from other people, I found my niche. So yeah, I'd say put your energy into something that you're passionate about, and you'll realize your strengths. As I said, I didn't even think I thought I didn't like science when I was in secondary school, and now I'm a scientist because I love it, and it just drives me. I cannot consume enough research and be as immersed. I can't be involved enough. It just drives me.
You're not just a scientist, you're a doctor scientist. But you don't wear a white coat, I don't think, do you? I haven't seen you wearing a white coat around the place.
No, different kind of scientists. We wear trainers and go to the gym, which is good fun. And we get to work, people with mental health problems that, we get to connect with and talk to. There's just some great people out there, and it's rewarding. I can't put it any other way. It's really, really satisfying to see people, getting involved with something that they thought they wouldn't be able to do, and then realizing that it's having a good impact for them. It's very, very rewarding to see that and to be involved in that process. And it's a doctor by a different sort, but it's for me that's really rewarding.
Evan, if somebody wanted to find out more about your research or follow the kind of stuff that you're doing, where should they go? What should they do?
Yeah, so I have, you can email me, but you'll get more action from me on Twitter, I think. So my Twitter handle is Ev Matthews IRL, IRL in capital letters. So connect with me on Twitter is probably a good way. If you really want to consume some of the literature, you can check me out on Google Scholar or ResearchGate as well. You'll find me with a Google search there. But those are probably the best ways to interact with me. And I'm always open to talking to people as well, particularly people in WIT. We can always meet for a coffee and chat, which is handy. So
one last quick flippant question. The Ev Matthews IRL Twitter handle, is that Ireland or in real life?
I hadn't even considered it the other way, it's... That's me trying to be as safe with my Twitter name as I possibly can, I think. Yeah.
Brilliant. Yeah. Well, listen, Evan, thank you so much for speaking with me today. Thanks for appearing on the 9 Plus podcast. I wish you all the best with phase 2 of the exercise effect and all your various other adventures that you're having around the place. And we'll see you for a coffee again soon.
Thanks, Rob. Really appreciate your time. Cheers.
Thanks for listening to this episode of the 9 Plus podcast. If you'd like to learn more, check us out on wit.ie. On Twitter, you can follow the podcast at 9 Plus podcast. That's number 9 PLUS podcast. And if you liked what you heard, please consider leaving us a positive review on whatever podcasting platform you're listening on. That kind of stuff helps us reach a wider audience. So thanks again for listening, and we'll be back with another episode soon.